Welcome to the FH Global Summit. This is our 8th annual summit. Our overall theme of the summit this year is driving solutions to prevent inherited cardiovascular disease. This year, due to the pandemic, we are holding the summit as monthly virtual events. Today is our 5th session, and we will highlight a few of the cutting-edge advancements that will help improve care for individuals impacted with FH. I am Dan Rader, the FH Foundation Board's Vice Chair and the Chair of the Department of Genetics at the Perelman School of Medicine at the University of Pennsylvania. I'm co-chairing this summit along with Josh Knowles, the Chief Research Advisor for the FH Foundation and Assistant Professor of Medicine at Stanford University Medical Center. Before we begin, I'd like to make a few announcements. We'd like to ask you to please use the chat feature on the bottom of the screen to introduce yourselves, let everyone know where you're from, and to say hi to your friends. It's important to remember to change the setting to panelists and attendees if you want everyone to see your comments. Next slide. We'd like to take questions via the Q&A feature, different from the chat feature at the bottom of your screen. So please use this Q&A function for any questions for the speakers and panelists. You can submit questions anytime during their talks, and once they finish, we'll try to get to as many questions as we can. This session is being recorded, and a reply will be available via email in the coming week. We'd very much like to thank our 2020 FH Global Summit sponsors for their very generous support of this series. And in particular, I'd like to call out Esperion, a foundation partner for this summit series. We'd very much like to thank the FH Global Summit Steering Committee, 5 of whom are shown on this slide, for their tremendous insights and support in developing the content for this summit series. The FH Foundation is also hosting 2 webinars this month that you're all invited to register for. The first is tomorrow, February 18th, 7 Eastern Time, 4 Pacific Time, where Dr. Larry Sperling from Emory University will join Catherine Willimon for a discussion around heart disease prevention in a post-COVID world. In honor of Rare Disease Week on February 25th, Dr. Bart Duell from Oregon Health Sciences and Dr. Lisa Hudgens from the Rogosin Institute and Weill Cornell Medical College will join Allison Jameson, an FH Foundation board member, to discuss homozygous FH diagnosis and the latest treatment advances. Please join one or both of these sessions as you're able. And now I have the pleasure of introducing our first speaker in this session, Dr. Amit Khera. Dr. Khera is a cardiologist at Massachusetts General Hospital, MGH, and a group leader within the MGH Center for Genomic Medicine and also at the Broad Institute. Dr. Khera has contributed extensively to our knowledge of FH and polygenic risk for FH and cardiovascular disease, and he has performed pioneering work to quantify genetic risk through genome-wide polygenic risk scores. Amit, it's a pleasure to have you here today, and we look forward to your talk.
Thanks so much, Dan, and mostly just thanking you for the kind introduction. Really wanted to highlight an opportunity today to talk about how DNA is actually not destiny, and to think through new insights and opportunities to help patients with familial hypercholesterolemia variants. And as most in the audience know, familial hypercholesterolemia variants, it's a single base pair change among the 3 billion base pairs in our genome, which in and of itself can prevent clearance of bad cholesterol from the circulation. Many patients are born with triple or quadruple, even 10 times higher than normal cholesterol, and predisposed to markedly increased rates of cardiovascular disease, especially at an early age. And these mutations or variants are actually present in about 1 in 250 people in the population. So when we think about a key goal of precision medicine, I think one of the main hallmarks is really the opportunity to identify these very high-risk patients prior to the onset of disease. And here, I think that familial hypercholesterolemia is actually a very important prototype. So if we think about the traditional approach to finding these people, 1 in 250 in the population with these FH variants, the traditional approach was really based on LDL cholesterol or bad cholesterol and a family history. So doing genetic testing in people who came to the doctor because they had sky-high cholesterol, Or maybe they said, you know what, everyone in my family seems to have had a heart attack at a young age. And that was really a common trigger to get genetic testing. Now, this made a lot of sense because genetic testing was not widely available and extremely expensive. But we're now in an era where that's really changed. And I think it's an opportunity to revisit some of these assumptions that we've made previously. So over the last couple of years, we've really tried to think through the question, is LDL cholesterol, bad cholesterol, and family history, are they adequate proxies or markers for the risk that's actually conferred by these FH variants? So this is work I actually started as a postdoc several years ago with Sekar Kathiresan, and then more recently has led by folks in my own group, Amit Patel and Wallace Wong. So we first asked a very simple question, which is, for any given observed LDL or bad cholesterol, are these people who have these mutations at increased risk? If you come into your doctor's office with an LDL, say of 130, doesn't matter whether or not you have an FH variant in affecting your risk of developing coronary disease. So this is data that we presented based on a very large data set of gene sequencing data. Here on the x-axis, I'm just showing you individuals stratified by the LDL cholesterol that they came into their doctor with. And on the vertical axis is just their risk for coronary artery disease or heart attack. In dark blue is the people who had a variant, and in light blue is the people who didn't. So what you can see is actually quite striking. The blue bars are always quite a bit higher, regardless of what the observed cholesterol was. And this pattern, for example, those who had very mildly elevated cholesterol, 130 to 160, no variant, the risk was about 1.8-fold increase. But if they had a variant, it was actually almost quadruple, 3.8. And I can tell you that these individuals are typically not treated within clinical practice, especially with these very mildly elevated cholesterol levels, but really are flying under the radar. If we look at those with more severe hypercholesterolemia, we estimate that the risk compared to people with a normal cholesterol is about 5-fold increase. But if they also have a FH variant, we think it's about 17-fold. And this is despite the fact that the measured LDL cholesterol in these two groups is virtually identical. And we later went on to show that the reason for this is that FH variants are genetic variants. They're present from the time you're born. And this really leads to much higher cholesterol levels over the whole course of the lifetime. And that translates into markedly higher risk. So what does this mean? Well, it means first that among these very high cholesterol individuals, everyone's at high risk, whether it's 5 or 17, everybody really needs treatment to really overcome that inherited risk. But I do think that as we have more expensive or more therapies with more side effects, knowing whether you're 5 or 17 could be important in terms of shared decision making as we get more and more powerful interventions. But even more importantly, for those with a relatively normal cholesterol, this is an opportunity to identify among those individuals a high-risk group. So what about family history? So family history has been known to be a marker of increased risk for cardiovascular disease for almost a century, but it's really only within the last several years that we've had the tools to understand the molecular underpinnings of that association. So here was data led by Amit Patel, where we looked at 50,000 people of the UK Biobank. We went through and looked at every single genetic variant present in those people, and we found 131 of these people actually inherited an FH variant. As you might expect, their rates of cardiovascular disease were significantly higher, 21% versus only 9%. We then went on to look at survey data, and we said, well, how does family history track with these mutations? As you might imagine, it was higher, but it wasn't that much higher, 66% versus 44%. And what this told me is that the family history, in this case, we're just saying, did one of your parents have heart disease, track with presence of these variants, and it's really not enough to highlight these high-risk individuals. And we found similar results even when we asked much more sophisticated questions like how many people in your family were affected or what age they were affected. It really wasn't enough to reliably identify those who carried an FH variant. So what does that mean in terms of your risk? Well, here I'm showing you on the x-axis, the horizontal axis, age and years, and on the y or vertical axis, the chance that people develop cardiovascular disease. And here I'm showing you, in this case, male participants of the UK Biobank, but we showed the same results in females as well. So if you had a family history and an FH variant, we estimate a risk of developing heart disease about 67% by the time you were 75, versus no FH variant, it was only about 32%. For those who didn't have family history, the gradient was still 48% versus 22%. So what this means is that both family history and FH variants are important drivers of risk for cardiovascular disease and useful in terms of risk discrimination, but neither are adequate proxies of each other. So this data, so far really suggests that these people, 1 in 250 people and who inherit these FH variants, really are at high risk. That's not fully captured by their LDL and or their family history. We then said, okay, well, is DNA destiny? Meaning that if you have an FH variant, are these folks predetermined in almost to develop heart disease at a young age? Or might you imagine a favorable genetic background or a healthy lifestyle can really offset the risk? So here, this is data from work led by Akil Fahed and Wallace Wong in my group, and Julian Homburger, a collaborator at Color. So let's think from a conceptual standpoint. How might someone's DNA get them to coronary disease? And there are really two models. The first model is a monogenic model. This is an example like an FH variant. It's a single base pair change out of 3 billion base pairs, but it has a large effect, tripling or quadrupling risk. And it does so by disrupting a very specific pathway. People can't get the cholesterol out of their circulation. But a second model is actually what we're calling a polygenic model, poly meaning many. Here it's not one variant, but actually many variants scattered all across the genome. Each of them has a small effect. Most of them actually don't tag cholesterol-related pathways. It's many different pathways. But in aggregate, you might imagine their impact could be quite substantial. So we set out to quantify this polygenic idea, and we did it by developing what we call a polygenic score. So this is genetic prediction based on 6.5 million variants. So how do we do that? Well, we first designed what we call a genome-wide association study. We found 60,000 people with heart disease and 120,000 people who didn't have heart disease. We looked at how common each of 6 million variants that might differ from me and you in a common way were in these two groups. If a variant was more common in the people with disease, that was a risk variant. If it was more common in people who didn't have disease, that's actually a protective variant. And at the end of the study, we actually had a list of 6.5 million rows. And for each one, we had an estimate. Does it increase risk by 2%, decrease it by 1%, and so forth? We then used sophisticated computation algorithms to integrate information from all of these variants into a single number. Here I'm showing you the distribution of this number, polygenic score, in 125,000 people. What you can see is that it's not a 0 or 1 variable like an FH variant. It's actually normally distributed, like you might expect, things like blood pressure and cholesterol are. So it doesn't matter where you are in terms of this distribution. Here I'm showing you we tested the score in another 300,000 people. On the horizontal axis is just the percentile, the polygenic score. And on the y-axis is the percent chance that these individuals had coronary disease or cardiovascular disease by the time they reached middle age. In this case, they were in their 50s. So each dot actually represents 3,000 people. And what you can see is really a striking gradient ranging from about 1% for those in the lowest percentile to about 11% for those in the highest. So might you imagine that where you are in this polygenic score distribution modifies the penetrance of these familial hypercholesterolemia variants? So what do I mean by penetrance? Penetrance is the chance that you're affected by heart disease if you inherit a variant. And even though they triple or quadruple your risk, it's also the case, clinicians and patients have recognized for a long time that not everybody gets affected. So might this genetic background, what's going on in the remaining 6 million variants, actually be an important modifier of your risk? So to this, we looked at about 13,000 people. We first just looked at everybody with an FH variant, and we found that on average, the odds ratio was about 3. So these people were about triple the risk. Now I'm showing you what happens if we additionally look at the polygenic score. So on the horizontal axis, I'm showing you people been just low, intermediate, or high polygenic score, genetic background. And on the vertical axis is just the risk for coronary disease. So those who have the FH variants, or these bad variants, are seen in blue. Those who don't are seen in dark gray. What you can see is that there's a significant gradient. So those who had a low polygenic score, a good background, but an FH variant, their odds ratio is actually only 1.3, meaning they were about 1.3 times as likely to develop heart disease. Risk was actually comparable to the population average. By contrast, for those who had both a high polygenic score and an FH variant, this is what we consider a genetic double whammy, and we estimate 13-fold increased risk. So we then generalize this idea to another 50,000 people. And so the traditional approach is to say that people with FH variants are at high risk. So here I'm showing you on the y-axis, the vertical axis, the chance that folks developed heart disease by the time they were 75. FH variant carriers seen here in blue. In our study, the risk was about 41% versus people who didn't have this FH variant was 13%. So about a tripling of the risk. We then said, okay, well, what happens if you now layer in the impact of the polygenic score? So in the gray dots, I'm showing you what I showed you earlier. In non-carriers, most people, there's a significant gradient. But look what happens when we now look at the blue dots. And this is saying that even among people with these high risk FH variants, there's really remarkable risk stratification. Your risk varies from 18 to 80% based on where you happen to be in the distribution of this polygenic score. So we really are moving to a time where state-of-the-art genome interpretation, looking at someone's genome and interpreting the risk for important diseases, requires looking both at the traditional approach for these FH variants, but also this polygenic score. And from the time of birth, we can put people in any of these 200 dots. If they have no FH variant and a low polygenic score, we estimate a risk about 4%. But if you have this double whammy, we estimate your risk is about 80%. So I think this is a very valuable tool in terms of risk stratification and to guide treatment decisions moving forward. So what have we learned over the last several years from this idea about polygenic scoring? And there are a number of groups who really pushed this forward recently. First, it distills your inherited risk into a single number. It's available from the time of birth. So really we have the opportunity to give people a decades-long head start to overcome inherited risk. The risk prediction actually exceeds that of traditional risk factors like blood pressure and cholesterol. These high polygenic score individuals are currently flying under the radar within our clinical practice. We can't identify them using traditional tools. It's actually much more common than these rare FH variants. We can find people who are triple the normal risk, but it's not 0.4% of the population, but actually 8%. So it's much more common than these FH variants. And even for those who have an FH variant, as I mentioned, it really modifies the risk. Lastly, from a single test, from a single DNA test, what we're really talking about is an opportunity to measure your risk for a whole range of preventable diseases. Here I'm showing you data from atrial fibrillation, diabetes, inflammatory bowel disease, breast cancer. Essentially every common disease, we can use the same tool, demonstrate the same pattern where there's some people with very high and other people with very low inherited risk. Now, a second use case might relate to another thing that's very near and dear to the heart of the FH Foundation. These are people who don't have a FH variant, but rather inherit very high levels of lipoprotein A. This is a cousin of bad cholesterol. That's also a very important determinant of risk for cardiovascular disease. But what we found is this is almost never measured in clinical practice, but we can make a polygenic score to predict who's most likely to have a high lipoprotein little a. And this is work led by Jacqueline Duran in our group and recently published. And what it really says is that in a future where many people have genetic information, we can use a test like this as a clue for doctors to say, you know what, maybe I need to measure lipoprotein A in these individuals because it may be an important driver. And this will become increasingly relevant because there's some medicines in development that are actually specifically targeting lipoprotein A, which we'll get data for in coming years. So what about lifestyle? I talked a little bit about genetic background. So is it true that a favorable lifestyle can really decrease your risk, as does most people, but among those with an FH variant? We did something very simple. We used 4 criteria: no smoking, normal weight, exercising regularly, having a healthy diet. We said if you have at least 3 of these factors, you're a favorable lifestyle, 0 to 1, unfavorable, and those in the middle were considered intermediate lifestyle. What we found in looking at all comers, the risk of an FH variant was about triple, odds ratio of 3.1. But now look what happens when we integrate the impact of a lifestyle. So what you can see is the blue bars, again, are people with an FH variant. And the risk compared to the average person, it ranges from 1.4 times increased risk to actually 6 times increased risk based on your lifestyle. And when we then go on to estimate your risk of developing disease by age 75, you see the same thing, where the absolute risk range from 34 to 66%, according to whether or not you had a favorable or unfavorable lifestyle. So there are 2 important points. One is that the blue bars never got to the point of the non-carriers. These folks were always at higher risk, at least in this study. But the ability of a favorable lifestyle to powerfully modify the risk, but essentially cut it in half, I think is quite important as a message in terms of delivering to our patients and really empowering them to overcome inherited risk they may have been born with. So this is kind of the central dogma of familial hypercholesterolemia. You start with a variant, it leads to increased LDL cholesterol and leads to atherosclerosis or heart disease. But what we're really talking about now is the ability to have a much more sophisticated approach where whether you have 1 variant or 2 variants, FH variants, and the exact variant you have is important. And we know the impact on LDL cholesterol actually varies a lot based on medicines, diet, lifestyle. Similarly, even if you have an LDL cholesterol, whether you developed a heart attack is not a given. And I showed you polygenic background is quite important, lifestyle is quite important. And again, traditional risk factors like control of diabetes and hypertension is quite important. So really, I shared just a couple anecdotes, but we're really moving towards an opportunity to having an integrated risk model where we integrate all of this and really help guide patients and doctors in terms of what therapies and what screening might be most appropriate. So what about these patients with high genetic risk? What about at a hospital like Mass General? Are these people actually being recognized in current clinical practice? Here's work led by Dimitri Momari and Deanna Brockman in my group. And we looked at 13,000 patients from our hospital where we had genetic data. They volunteered to be part of our biobank. We first found that FH variants were present in about 0.3%, just as we expected. They had about quadruple the risk for coronary disease. But what was really interesting is we were able to look back at their medical record. And we found, and this is consistent with what the FH Foundation and others have found, is that the majority were underdiagnosed and the vast majority had cholesterol undertreated with respect to where we need to get patients. In fact, 16% of these people, even though they had this very high risk variant, had never had their LDL measured in clinical practice. We don't even know what it was. Here's one example where there's a 42-year-old woman who came in with a heart attack at very high untreated cholesterol. Here I'm showing you members of her family, and each gray dot that's shaded in is a person in the family who had coronary disease, and everybody in her family was affected. Her sister died at 31. Another sister died at age 40. And we then went back and said, okay, well, might her genetics have played a role? And here what we found is she had this double whammy. She had an FH variant, and her polygenic score was in the 91st percentile. So she's seen here in this red dot. So she inherited from the time she was born greater than 10 times the increased risk. But this was totally uncaptured, and she really wasn't treated until after she came in with a heart attack. And even to this day, nobody knows that their polygenic score. So, when we think about these types of models, we really came to the conclusion that we needed a clinical infrastructure to use genetic information to better understand, predict, and prevent disease. And we launched a Preventive Genomics Clinic in late 2019, embedded within primary care, which is really where I think preventive genomics is going to live in the future. One important bucket of patients is to guide asymptomatic individuals who have an FH variant. Some people come to us, but we're also systematically going out and trying to find them by gene sequencing, doing genetic testing in 60,000 people who volunteered to be part of our biobank, and disclosing that they might have an FH variant and helping them overcome that inherited risk. We think it's straightforward to show that we can reduce their cholesterol, but we then said, is there an additional opportunity to actually demonstrate the value of this approach? And we recently got IRB approval to show that we can do a CAT scan, a sophisticated test to actually measure the plaque. And what's interesting here is that you can actually reverse the plaque over 12 years. So we have an opportunity to quantify how much plaque these people have in their blood vessels of their heart, and then really show that by getting them on the right medications, nutritional counseling, and lifestyle, really working with them, we can really demonstrate disease reversal. And I think these early examples for genomic medicine will be quite important as we seek to build a genetic database. We've also seen patients who are looking to discuss testing for symptoms or family history. And lastly, we think anybody who wants to come in and have their genome interpreted for these important diseases, we want to be able to offer that. And to that end, just in December, we actually launched the first test. This is a collaboration with Color, a population genomics company in the Bay Area. The first test to really look at both monogenic FH variants and polygenic risk for coronary disease. Say which of these 200 dots you're in. And we started to disclose that risk over the last 2 months to patients. As a clinical test, we put in the electronic health record. This test costs about $249. At the moment, it's not covered by insurance, but again, we're looking to generate evidence. And we're able to have pilot funding to offset the cost for the first 100 patients. The first couple of patients we've seen, 49-year-old came in with a heart attack with no traditional risk factors. Why did this happen to me? Might genetics have played a role? A 30-year-old woman who had a very mildly increased family history, but a strong family, a mildly increased cholesterol, but a strong family history. Should she start a medication, and might genetics play a role in that shared decision-making that I have with her? So I think we're really at an exciting time where there are new insights and opportunities for people with these FH variants. I think I showed you that the risk associated with variants persists, even independent of what the LDL cholesterol or family history is. And neither of these are really adequate proxies for the presence of a mutation. DNA is not destiny. So both polygenic background and a favorable lifestyle meaningfully offsets risk. And this really lays a foundation for an opportunity to help individuals, empower individuals to overcome whatever genetic risk they were born with. And lastly, we're quite excited about this Preventive Genomics Clinic, which really provides infrastructure to demonstrate clinical utility, finding these people, including an opportunity to demonstrate disease reversal. And so this is something that we are eager to work with sites across the country. I know Josh Knowles, who's well known to FH Foundation, is planning something similar at Stanford in coming months, and Penn as well. And so we really think we're going to have a network of places where we can really build the experience and the evidence base for how we use these new tools in clinical practice. Thanks so much, Dan, Josh, and Catherine. And I'll turn it back over to Dan and look forward to questions in the question and answer period.
Amit, thank you so much. That was really terrific. And we have some questions already, and I think more are going to be coming in. Derek Rawl wanted to ask about the issue of the number of SNPs that go into polygenic risk scores. Of course, early variants of this, variations of this had 6 or 12 SNPs. You use 6 million. Does it really matter? Can you just speak to that issue of how many SNPs factoring into the score?
Yeah, the question is, how many variants do you really need to capture this polygenic score? And what we found, actually, we have no horse in the race. We actually did a direct head-to-head comparison of a score that was published several years ago by our group with 50 variants versus 200,000 variants versus 6 million variants. And what we find is that the risk gradient really does improve when you use what we call a genome-wide set of variants. And what's interesting to know is that the cost of doing that is actually the same. So what you can use, the technology has progressed to the point where the cost of getting the 50 variants or 6 million variants is actually the same. It's available for under $100 using current technologies. So in head-to-head comparisons, we really do see important improvements going from 50 to 6 million variants.
As you know, there's been a lot of discussion about the use of polygenic risk scoring in non-European ancestry individuals and the relative lack of data. Can you just speak to that issue? And practically speaking, are you offering this current pilot that you have at MGH only to people of European ancestry, or are you offering it more broadly?
Yeah, it's a critically important point, and that's actually maybe the most important focus of my group for the next couple of years. But the current situation is that the score predicts risk in everybody, all ethnicities, but the effect size is actually greatest in people of European ancestry. And the reason for that is quite simple. It's simply where we had the most training data. But we've set out to really aggregate the world's data, which is increasingly available in non-European ancestry, and also started using more sophisticated computational algorithms to, again, narrow the gap in terms of the disparities. But in terms of our clinical practice, we do think that there's value even currently across all ethnicities. What we actually disclose is where people are in the distribution. What is the percentile? And we're able to very reliably compute that, even comparing you to other people with your same ancestry. But it is true that the actual effect size, maybe you're at double the risk instead of triple the risk if you're non-European. And so that is an important caveat in terms of how we counsel patients downstream.
Question about polygenic risk scores that might help understand people who don't develop disease despite having exposure. So the other end of what you emphasize, which is high scores predicting increased risk. We've all seen patients with LDLs of 300 who live into their 70s and 80s without cardiovascular disease. Can you use polygenic risk scores as a way to try to help explain why some people might be protected against exposures that should produce disease?
Yeah, I think that we and others have shown that's definitely true. So and so it's basically, if you have an FH variant, but your polygenic score tends to be is very good, all these other pathways are really offsetting the impact of an LDL cholesterol. And so we've been able to show that's a powerful modifier. And really, if you have an FH variant and a very high LDL, your risk actually may be quite much closer to the population average if you have a very good polygenic background. But really only now able to really integrate both into a single model to, again, predict risk. And ultimately, if someone with high LDL cholesterol, I do think should be treated aggressively. But this more nuanced and sophisticated and accurate prediction modeling, I think, will be important moving forward.
You're a cardiologist. How do you feel about coronary calcium scanning and its relative role vis-a polygenic risk scoring in helping assess risk?
Yeah, so coronary calcium scanning is really looking for very early signs of disease by early plaque buildup in the vessels of the heart. And I think that both genetics and this calcification have really important roles. And the real advantage of genetics is we can do it from the time of birth. So as I learned from you, Dan, working in your clinic, 15 years ago, is that most patients in their 20s and 30s, they actually don't have calcification. So the test really isn't that useful. But I think as people get into middle age, I think it does become more useful. And I think so. I think there's an opportunity to really use them in tandem. And I think they're actually both useful at different ages, but the relative value I think does shift over the course of the lifespan. I will say that, some people, I don't want people to be overly reassured by a negative calcium scan, because I think a normal calcium scan, even if an FH variant, for someone who's 70 or 80, I think is very reassuring because they didn't develop plaque despite the fact they had this variant. But if someone's in their 20s, 30s, even 40s, I actually don't find it particularly reassuring. And I do think, as you do as well, that we really need to really aggressively treat those individuals, or at least offer aggressive treatment.
That's great. Amit, I think we're gonna move on, but thank you again so much for a really terrific presentation. Really appreciate it. So we're going to move to our next presenter. I'm really pleased to introduce Kate Robinson. Ms. Robinson is an advocate and an individual impacted by FH, and she is going to share her family's journey and her perspective with all of you. Kate, thank you so much for joining us.
Thank you, Dan. Thank you to the FH Foundation for inviting me here to share our story. I hope it sheds some light on why these developments and research efforts are so critical to those families living with FH. My husband Dave and I have 3 children. Cameron is 8, Colin is 6, and Molly is 3. And our journey with FH began when our son Cameron was 4 years old, and we noticed some small bumps behind his knees and his elbows. Unfortunately, at the time, we did not understand the crucial significance of these tiny bumps, as we were told it was skin molluscum and just to simply keep an eye on it over time. Over the next few months, those bumps got larger and more pronounced in size, and we eventually took him to a dermatologist to get a second opinion. Unfortunately, the biopsy results were absolutely devastating. We were told that these were cholesterol xanthomas and that Cameron needed to see a cardiologist immediately. To say we were shocked is truly an understatement. We were lost and confused. My husband had high cholesterol ever since he was tested in his early 20s, but no doctor had ever mentioned FH or encouraged us to get our children tested at a young age. We lost almost a year of treating Cameron appropriately because we did not understand the warning signs of this fight that was to come due to those little bumps. We immediately saw a cardiologist at Boston Children's Hospital that specialized in HoFH and HeFH. Finding a specialist was critical to our family. When we first got Cameron tested, his LDL was 897 at the age of 5. At the same time, he had a coronary CT scan done, and he had already had a 90% blockage in his right coronary artery. As you can imagine, this absolutely shattered our world. How could this active little boy who looked so healthy on the outside have such advanced heart disease on the inside? Within a few weeks after that, Cameron had surgery to have a port placed in his chest, and he started apheresis treatments thereafter. He has gone almost every single week since. As of today, he has received 154 treatments at the age of 8. And to think that this number doesn't even include all the routine appointments, such as echocardiograms, EKGs, stress tests, and routine doctor follow-ups. This is a lot for such a young child to process. He was only 5 when he started spending close to 7 hours every single week at the hospital. Although we explained to Cameron that there was no other option, that he had to do this, this was not easy for him to digest. When we started his treatments, we had to engage the behavioral response team at Boston Children's Hospital to meet me at the car before each treatment, because his fear was so paralyzing to him that I physically could not remove him from the car. It was crushing. We also had to engage a child psychologist to do bedside counseling. It was a lot to watch a child to go through. Now, luckily, 3 years later, Cameron has no anxiety surrounding his treatments, and I am constantly in awe at his strength, resilience, and perspective that he has on life. Now, unfortunately, Cameron is not our only child with HoFH. At the time of Cameron's diagnosis, we also got our other 2 children tested. Our son, Colin, who was 3 at the time, had an LDL of 190, and our daughter Molly, who was 6 months old at the time, had an LDL level of 704. As such, Colin was determined to be HeFH and Molly was determined to be HoFH. Now, Molly is currently on a combination of rosuvastatin and ezetimibe. However, this only brings her LDL down to 669 as it currently stands. The additional problem for Molly is we are unsure if she will be able to do apheresis as Cameron does, as Molly also has a genetic disorder called microcephaly that has resulted in global developmental delays. Now, on average, it takes Cameron about 6 hours each week right now to receive his treatment. It is unclear at this time if Molly will be able to sit still for that length of time. As such, if medication cannot get Molly's LDL levels under control, then Molly potentially could have to do a liver transplant to save her life. There is an urgent and unmet need to treat these children living with HoFH who are unable to receive apheresis or take certain medications. I want people to know that it is important to diagnose FH, screen the entire family, and treat early to prevent cardiovascular disease in both HeFH and HoFH individuals. Now, my husband Dave was 20 years old when he was started on a statin because his LDL was at a level of 400. Ever since that point, Dave has been on a statin and most recently a PCSK9 inhibitor, which has gotten his LDL levels under control. However, the problem is the damage had already been done. Dave started to experience chest pains 3 years ago. Now, unfortunately, regardless of his history of high cholesterol, our children's diagnosis of HoFH, his cardiologist at the time said it was probably heartburn and prescribed him Prilosec. Now, after experiencing chest pains for over a year with no answers, Dave finally went in for an angiogram, and we are so extremely lucky he did. That morning, they found that he had 2 blocked arteries, one at 80% and one at 85%. He had 2 stents placed that morning. Luckily for us, Dave is now feeling great and his numbers are under control. We are extremely grateful to have an amazing team of doctors and a care management team that truly understands the complexity of living with FH. However, the burden of living with FH, especially for a child, goes well beyond the medical diagnosis. The burden of living with FH for a child spills into everyday life. It determines what sports they can and cannot play. It evokes concern and worry in other parents to have them over for a play date, wondering if they will have a heart attack under their watch. It makes them feel insecure when other kids point out the port in their chest. It makes them miss a day of school every single week to receive their apheresis treatment. It determines where they can live or where they can go to college because they have to live close enough to an apheresis treatment center. FH affects an entire family. It takes time away from your other children. It forces a parent to take time away from work to help their children get their treatment options, or forces a parent to leave their job entirely. Each of these children deserves to live the simplicity of childhood that is such a rite of passage for so many. This disease strips that privilege away from so many children living with FH. And this is why I will continue to use my voice to advocate for awareness, for better treatment options, so that those children can receive those treatments and restore some sense of normalcy to their lives. Listening to these renowned doctors speak about what is on the horizon has brought such hope and promise to those of us living with FH. These efforts provide the strength that we need to fight this fight for our spouses, our children, and the generations to come. Thank you.
Kate, that was just so amazing. Thank you so much. If it's okay, we're going to leave to the panel the questions that individuals have for you and move on to our next speaker, if that's all right.
Thank you, Dan.
Thank you again. I'd like to turn now to our third speaker, Dr. Kiran Musunuru. Really a pleasure to introduce Dr. Musunuru. He's an associate professor of cardiovascular medicine and genetics at the Perelman School of Medicine at Penn, where he also directs the Genetic and Epigenetic Origins of Disease program at the Cardiovascular Institute. Dr. Musunuru has made amazing and outstanding remarkable contributions to the research in genetics of lipids and cardiovascular medicine. I could give several examples, but I'll just say here that he was the first to report that genetic loss of ANGPTL3 led to familial hypolipidemia with low levels of all major lipid traits, paving the way for ANGPTL3 as a therapeutic target and culminating in the approval just last week of evinacumab for patients with homozygous FH. He's internationally recognized as a leader in CRISPR-based therapeutic genome editing for lipid disorders and cardiovascular disease. And you may have noticed that he's sort of a go-to person for the press when anything new comes out related to therapeutic genome editing. Kiran has received numerous awards for his research, too numerous to mention, but I will mention that he received an early career award for scientists and engineers from the White House in 2016. We are really fortunate to have Dr. Musunuru with us today to tell us about his pioneering work in genetics and genome editing. Kiran, thank you.
Thanks so much for that kind introduction, Dan, and thank you so much to the FH Foundation for giving me the opportunity. It's a real pleasure and privilege to be able to speak to you about new frontiers of FH care. As Dan mentioned, I'm at the Penn School of Medicine at the University of Pennsylvania. My disclosure is I'm a co-founder and the senior scientific advisor to Verve Therapeutics. I'm not representing Verve in any way today, but I will show some data that has previously been publicly presented by Verve near the end of my talk. So the story I want to tell begins a little more than a decade ago when I was a postdoctoral fellow working with the gentleman on the right, say Katharayson. If you happen to have attended the FH Global Summit in 2019, which seems like such a long time ago now, but if you were there, you might remember Dr. Katharayson was one of the featured speakers. He and I shared the goal of trying to get a better understanding of the genetic basis of heart disease, and in particular, we're keen to find genetic superheroes in the general population. These are people who have been born with protective mutations that make them resistant to heart disease. And the hope is to identify the people, their mutations, and then use that knowledge to develop ways to prevent disease in the general population, keeping in mind that heart disease is the leading cause of death worldwide. And we were particularly inspired by the example of PCSK9, a gene very well known to this community. PCSK9 was originally discovered in 2003 by Dr. Catherine Boileau and her colleagues in France. Again, if you attended the Global Summit in 2019, you may remember that Dr. Boileau was the keynote speaker. A couple of years after the discovery, it was appreciated that people with a single mutation, one copy of the gene, halfway turned off, leads to lower LDL cholesterol, lower risk of coronary artery disease. And what got people very excited was the identification of a small number of individuals who have double mutations, who have both copies of the gene mutated, have the PCSK9 gene entirely turned off. And that results in very low LDL cholesterol. And at least in the few individuals who are found to have the double mutation, they're alive. As far as we know, they're well. There appears to be some measure of safety in entirely lacking PCSK9, which made it a very attractive therapeutic target. Now, fast forward to 2015, and we had the first US FDA-approved PCSK9 inhibitors available to patients. These are, of course, the monoclonal antibodies of elucumab and alirocumab. PCSK9 has a very favorable property in that it is made in the liver and exported into the bloodstream where it has its effects on cholesterol. And so there are actually two opportunities to target the gene. You can target it directly in the liver, or you can target the protein product in the bloodstream. And so the monoclonal antibodies, upon injection, are able to work their way into the bloodstream and then bind and inhibit the PCSK9 protein and turn it off that way. Now, I would be remiss if I didn't mention the new kid on the block, a new type of PCSK9 inhibitor, inclisiran, that's based on a technology called siRNA. And inclisiran can actually go directly to the liver and target PCSK9 there in the liver, so turning it off at its source, so to speak. Inclisiran was originally developed by Alnylam Pharmaceuticals and the Medicines Company, and now its development is being shepherded by Novartis. It was approved just a couple of months ago for use in Europe, and the expectation is that it will receive approval from the US FDA perhaps later this year. The results of this clinical trial published last year that you see here, I know Dr. Rall is with us today. These are patients with heterozygous FH treated with inclisiran, which is typically given on a schedule of every 6 months. On the left, you can see that the PCSK9 protein in the blood has been decreased, something on the order of 70% in the patients receiving the medication. And that translates, as you can see on the right, to a reduction of LDL cholesterol, time averaged reduction, probably around 40% or maybe a shade less than that. So it clearly works. Now, there is an interesting feature to note in that right-hand graph, and that is there seems to be this sort of seesaw pattern. And this reflects that even though the drug will be given every 6 months, it probably doesn't quite make it all the way out to 6 months. The effect starts to wear off before the 6-month time point. And so you can see that you get the drug and then the effect starts to go away before 6 months is up, then you get the next dose and then it goes down again, then LDL starts to creep back up. And that's why you're getting this, this sort of a seesaw pattern. And that's an important point. So keep that in mind, that 6-month threshold. What this is showing us is that there's no PCSK9 inhibitor yet that has been shown to go up to 6 months with respect to its LDL lowering effects. The other point I should make here is that these are patients with heterozygous FH. And we know that patients with homozygous FH, the more severe form, don't respond as well or even at all to PCSK9 inhibition. And that has to do with the mechanism of PCSK9 inhibition and its interaction with the LDL receptor, which patients with HoFH largely lack or entirely lack. So we really need other approaches, other modalities to be able to treat these most severely affected patients. So going back to the search for genetic superheroes, Dr. Gus Schoenfeld, the late Gus Schoenfeld at Washington University in St. Louis, identified a family typified by the person you see on the left, Anna Fuhrer. She was the index person, so to speak. She came to Gus's attention because she was found at an employer health fair, of all places, to have an extremely low cholesterol level, LDL cholesterol level. And Gus found that she also had an extremely low triglyceride level. He recruited her and her entire family into a research study and found that 3 of her brothers had the same condition, what we now call familial combined hypolipidemia, very low LDL cholesterol, very low triglycerides. Gus was very keen to identify the responsible gene, but he was limited by the technology of the time. So we're talking late 1990s into the 2000s, and he never was able to find the gene, and he ended up retiring. Now, fast forward to 2009, Sake and I read a series of papers published by Gus about this family, and we were excited because we had access to this exciting new technology called exome sequencing, which allows us to sequence all of the 20,000 genes in the human genome at one time, relatively inexpensively. So in 2009, it was new. We realized that we might have the means now to actually figure out this unsolved case. So we wrote to Gus. He was retired, but the DNA samples from the family were still available, and he arranged to have them sent to us. And we applied exome sequencing in the hopes of discovering the responsible gene. And we were in fact able to do so. So we can, to PCSK9, we can add ANGPTL3 or angiopoietin-like 3. It turns out that Anna and her 3 brothers with the condition of hypolipidemia are all double mutation carriers, both copies of the gene mutated. In all of the 4 siblings, ANGPTL3 is entirely turned off. And that leads to very low LDL, very low triglycerides, and it's clearly safe because you have these siblings who are alive, healthy, have made it to a ripe old age, have children and probably grandchildren by now. And there have been a few dozen other individuals around the world who have been found to be double mutation carriers, and there appear to be no adverse consequences. Sake and I and others went on, actually Amit was involved in this work too, went on to study about 1 in 300 people who have 1 copy mutated, who have the gene halfway turned off. And that results, not unexpectedly, in low LDL, lower triglycerides, but more to the point, substantially reduced risk of coronary disease. And we have evidence that there's actually substantially reduced risk of type 2 diabetes as well. So potentially a quadruple whammy if you inhibit ANGPTL3. Now, there's another nice feature of ANGPTL3 in that it's a lot like PCSK9 in that it's produced in the liver and then exported into the bloodstream where it has its actions. And so once again, there are 2 potential opportunities to inhibit ANGPTL3. So not unexpectedly, there are several companies who are intensely pursuing ANGPTL3 as a drug target. The first to reach the finish line, as Dan alluded, evinacumab, which is a monoclonal antibody against ANGPTL3 from Regeneron. It just received approval last week from the US FDA. And another of Dr. Rall's studies shown here, the clinical trial published last year, these are patients with HoFH, homozygous FH. Treated with evinacumab, it's an infusion, an IV infusion that's given once a month, or at least that's how it will be prescribed. And what you can see here is that there's something approaching 50% reduction of LDL cholesterol levels in these patients. And keep in mind, again, these patients don't respond well or at all to PCSK9 inhibition. So this is actually very exciting that there's an entirely new modality of ANGPTL3 inhibition that could help these patients. So now I want to step back and think not only about these new cutting edge therapies, but the old ones as well. They all share the property that they constitute chronic therapy for a chronic disease. They have to be taken again and again and again for the rest of one's life. So if you're talking about statins and ezetimibe and, and what have you, traditional pills, you have to take those every day for the rest of your life. If you're talking about PCSK9 and now ANGPTL3 antibodies, injections every few weeks for the rest of your life. Even the new kid on the block, inclisiran, it lasts longer, but you're still talking about injections every 6 months without, fail for the rest of one's life if you want the therapeutic effect. And so it's not surprising that adherence is an issue. This is a big burden to place on patients. They have to get access to the medication. They have to pay the copays, deal with insurance companies, have to worry about continuing access to the medical system. That is a very big burden. And not surprisingly, a variety of studies have shown that many patients stop taking the medication at some point. And so again, if you were at the 2019 FH Global Summit, you might remember there was a talk by Dr. Fatima Rodriguez, where she reported her study of patients who had had heart attacks, had gone to the hospital, and had been treated, and then discharged from the hospital with a prescription for statin therapy, and found that almost half the patients were no longer regularly taking the statin drug a year later. And this has been seen in actually several studies with statins, as well as multiple studies with PCSK9 inhibitors. Adherence falls off, and that's not surprising. And this highlights a big issue, a big problem in care of FH and cardiovascular disease writ large. And that is that medications don't work if you don't take them. Now, there are some patients for whom the implications of chronic therapy is actually much greater. So we just heard Kate Robinson very movingly speak about the ordeal faced by her son Cameron, having to undergo apheresis every week. This is an article from my hometown paper, the Philly Inquirer, published a couple of years ago, featuring Avery Watts, who also has homozygous FH, and you can see her receiving apheresis there, and she has to receive it every week. And in fact, I think her mom, Michelle, is with us today. This is not just medications you're taking, every day, or injections you're getting. This is apheresis week in, week out, indefinitely, as things stand now. Now, this particular article asked the question, can CRISPR fix the problem? Can it address a condition like homozygous FH? So let's talk about CRISPR. So you've heard about CRISPR, you may not have a great sense of how it works. And for today's purposes, it's actually not that important how it works. I'm more interested in showing you what it can do. And so there are various types of CRISPR technology. I'm showing you two forms here. On the left is what you can think of as version 1.0, the original form. CRISPR can go through the whole genome, kind of like GPS, and find the exact place you want it to go, a target gene like PCSK9 or ANGPTL3. And once there, it cuts through the gene, and that cutting can lead to disruption and turning off of the gene. So you can kind of think of it as molecular scissors. On the right is a newer form of CRISPR technology called base editing. And this is actually more precise, more elegant in how it works compared to the original CRISPR. So here, again, it finds the target gene, but instead of cutting through it, it can actually replace one letter in the gene with another. Kind of like a pencil and eraser. It erases a letter and then replaces it with another one. And so it actually has the precision to be able to change exactly one letter in the 3.2 billion letters in the human genome. That's the level of precision we're talking about. And so if you make the right letter change, you can actually turn off a gene as well. So both of these technologies will allow you to turn off genes. And just for fun, I want to show you what CRISPR looks like. So it really is a little molecular machine. Now, in the middle of this machine, you can see that there are blue and green strands. Those are actually DNA, and you can kind of see how they wind around each other, the DNA double helix. And then around the DNA is the CRISPR machinery. And so CRISPR actually can scan along a DNA molecule, scan entire chromosomes until it finds the target site, the target gene. And once it's there, other parts of the machinery then either cut through the gene like a scissors, or change a base, erase a letter, replace it with another letter. Okay, so what can you do with CRISPR? So my laboratory at the University of Pennsylvania has been working for a number of years now to try to use CRISPR technologies to turn off genes like PCSK9 or ANGPTL3 in the liver, directly in the liver, in various mouse models. And so you see an example here. These are slices of livers taken from mice. On the left is an untreated mouse. On the right is a mouse that received a base editing treatment. The brown color you see on the left, the brown that is all throughout the liver, that's the presence of the protein that's made by the gene we're trying to turn off. And so as you expect, it's all throughout the liver. It's there basically in most of the cells. On the right, you can see after the treatment, the brown is almost entirely gone. The protein is almost entirely absent. We've been able to turn off the gene essentially 100%, wiped it out of the liver. And I should also emphasize that this is not a short-term effect. The effect you're seeing there on the right, that's essentially permanent. The change is made at the DNA level, and so that effect lasts for the lifetimes of the mice. So that's very exciting that we can turn off a gene like that. So then we applied it to the question at hand. So a mouse model of homozygous FH, LDL receptor knockout mice. You can think of this as an avatar of sorts for patients with the disease. And remember, PCSK9 inhibition doesn't work so well in HoFH, so we went after ANGPTL3 with base editing, delivered it to the liver to try to turn off the gene, and it worked. We're able to reduce LDL as well as triglycerides, both by more than 50%. And a picture is worth 1,000 words, and you can see it right there. These are plasma samples from the mice, basically blood with the red blood cells taken out, so you don't see the red color. On the left is an untreated mouse, and you can see all the gook in there. That's all the cholesterol and triglycerides and fat content there in the plasma, making it almost opaque. And this is very much what an HoFH patient's plasma looks like right before getting apheresis. On the right, you can see a treated mouse. It is almost entirely cleared up. And again, that's a permanent effect, or in principle, a permanent effect. So you can imagine if there was a therapy available for patients with homozygous FH that could do base editing of ANGPTL3, there's the potential to have that patient's plasma turn from that on the left to that on the right for a very long time and potentially permanently, a once and done therapy. So Verve Therapeutics has been building on the work from my laboratory and others' laboratories, extending the work from mouse models to non-human primates, monkeys, and you see some of those data here. These were presented by Verve at a conference last June. And so here they've targeted ANGPTL3 in the liver with base editing. And I want you to focus on the red ovals. You can see that the amount of ANGPTL3 protein in the blood was turned down 95% 2 weeks after receiving the therapy. And on the right, you can see that translates to about a 65% reduction in triglyceride levels in 2 weeks. And although it's not shown here, there was also a substantial reduction of LDL cholesterol, reflecting the double whammy effect of ANGPTL3 inhibition. And they did the same with PCSK9. And so again, in the middle, you can see that PCSK9 protein levels were dropped by 90%, close to 100%, not quite there, but pretty close. And on the right, that resulted in almost 60% reduction in LDL cholesterol levels. Now, there are other medications that can reach that level of LDL reduction. Statins potentially can do it. PCSK9 antibodies can do it. But remember, all of them have short-term effects. They're medications you have to take again and again. So these are 2-week data. The question is, since the changes have been made in the DNA with the editing, will the effects last for a very long time, longer than the existing medications? And so last month, Verve gave an update, some of those same monkeys, but now followed for 6 months. And what you can see with PCSK9 protein in the blood on the left, with LDL on the right, after the drops at about 2 weeks, all the way out to 6 months, there is no hint whatsoever that the effect is going away. It is rock steady. And you look at data like these and you come away with the impression, wow, it's possible that these reductions will endure for the remainder of the lives of these monkeys. And so on the basis of these data, Verve has announced that they are hoping to be able to initiate first-in-human studies next year. So speaking as to which patients would benefit from editing therapies of the sort that we've been discussing for the last few minutes, well, certainly I think patients with FH would make a lot of sense. FH is a genetic disease. It is a primary genetic issue. So what better way to address it than a genetic therapy to reverse the effects of the genetic problem? But of course, it wouldn't be restricted to patients with FH. You can imagine it being helpful for patients with heart disease, the many patients worldwide who are suffering from heart disease. And so my vision or my dream or what have you is that we can transform the care of patients with heart attacks. So nowadays, 2021, patient comes into the hospital with a heart attack, has work done with balloons and stents and whatnot. You've treated the immediate problem. The standard of care is to send them home with a prescription for high-intensity statin therapy, because we know that if the patient takes that statin, that will reduce their risk of the next heart attack. But as you've heard, there's an issue, and that is the issue of adherence, that many patients stop taking the statin for whatever reason. So my vision is that you could switch to a model where a patient comes into the hospital after having a heart attack, has the immediate problem addressed, and then before they leave the hospital would get a once and done therapy that would permanently reduce their cholesterol and or triglyceride levels and offer lifelong protection and remove the burden from the patient for having to take therapy day in, day out, week in, week out, month in, month out, whatever it happens to be. Remove that burden from them and really allow them to enjoy the full benefits of the therapy from the get-go before they have even left the hospital. And in the long run, you can imagine that if the therapy is proven to be effective and more importantly, proven to be exquisitely safe, you can start to think of this not as a therapy, but maybe even as a preventive. So take patients at high risk for cardiovascular disease, maybe a strong family history, a high polygenic risk score, as Amit discussed earlier, a high calcium score. Those patients might be appropriate, might be willing to receive an editing therapy to reduce their future risk of cardiovascular disease, to be able to take one therapy and get lifelong protection. It's not immunological in nature. It's not exactly like a vaccination, but conceptually, it's not all that different. And so with that, I thank you for your attention, and I look forward to the panel discussion we're about to have. Thank you.
Kiran, thank you. Really clear presentation, really fascinating work, and congratulations on what is truly groundbreaking in terms of therapeutic genome editing.
Thanks,
We're going to move to the panel discussion, so I'm going to invite the other speakers to come on video and unmute. And I would like to start with a paraphrase of a question we got from Scott Rodabaugh. And I'll point out that, Amit, you, in your slide, mentioned that a variant in an FH gene is non-modifiable, but Kiran might beg to disagree. So my question is, Kiran, your examples were essentially getting rid of normal genes for purposes of lowering lipids and preventing disease. Can you just comment on kind of the approach of using therapeutic genome editing to change a mutation that is pathogenic and revert it back to wild type as a way of treating genetic disease?
So that's certainly a possibility. If a patient has a mutation, you could try to use CRISPR technology to directly correct that mutation to a normal, or the scientific term is wild type form of the gene. The issue there is that unless it is a disease where most of the patients or a plurality of the patients have the same mutation, it's going to be very hard to make personalized therapies for every single patient with their own personal private mutation. If you have a mutation that's different from everyone else's, you would have to tune the CRISPR technology so it is specific to you. So you're talking about basically making, say, 1,000 different treatments for all the patients with FH who have 1,000 different mutations. So I find it more elegant to be able to use this one-size-fits-all sort of therapy where you're turning off a gene like ANGPTL3 or PCSK9, depending on the circumstances, which will reverse the effect of the mutation, even if you're not directly addressing the mutation itself.
Great, thank you. Kate, I'd like to ask you a question again. Just really thanks for your presentation. So many great comments on the chat. So this is kind of a tough question. There's no right answer, but this seems like the right setting to ask it. So the approach Kiran described is going to be going hopefully into the clinic at some point in the not too distant future. What is your thinking about whether you, as a as an FH family and a parent of FH children, what is your thinking about participating in these kind of early phase experimental genome editing studies? Excitement, trepidation? Would love to hear your thoughts.
Thanks, Dan. I think all of those emotions kind of run through our head. As you said, there's not one right answer here. As any kind of medication or trial is begun, you have to look at, what are the adverse potential effects going to outweigh, the benefits. And as I spoke about, there are a lot of burdens that children with FH and adults with FH have to face. And I think it is about changing a lifestyle for them. I have to say, listening to these presentations have brought so much hope and promise. Even just speaking with them last week, I walked away so excited that, they are groundbreaking. They are changing the future for so many of us. When it's easy to be doom and gloom about what may lie ahead for young children living with this, it's giving us a sense of promise that things are changing. I do think that it would be very exciting to be a part of these trials, as long as the research is done and we understand the adverse effects that could potentially happen. But I think it's a really exciting time to be a part of this community to kind of help science change people's lives. And I would be very interested in learning more about it.
Thank you. Kiran, that kind of leads logically into, can you just speak to the major tolerability, safety, and safety concerns related to this approach?
Sure. So they're really, when you're talking about a therapy like this, where you're giving the therapy once and then it has a permanent effect, there are really two types of potential adverse effects you have to be concerned about. One is the acute phase. So the actual therapy itself, does it have any consequences in the short term? And then, of course, there's the editing long term. So let's take those one by one. So the short term effects, it turns out that the therapy that Verve is developing will sound very familiar to many of you, even though it would not have sounded familiar to you a year ago. And that therapy is actually a lipid nanoparticle surrounding messenger RNA. And if that sounds a lot like the COVID-19 vaccines that millions of us are now receiving, you're absolutely right. And it's based on the same technology. And so, there are some issues. If you're getting an infusion of LNPs, can you have an allergic reaction? Can, it cause a transient surge in, liver enzymes? Those are things to watch out for. Now, I would note that there are other LNP drugs. Patisiran, which is an siRNA drug from Alnylam, has been used in the clinic, and those patients are actually getting monthly infusions or maybe even more frequent infusions. So it shows that LNP-based drugs can be given safely, But of course, you have to do the studies, you have to monitor patients in the clinical trials and be sure that it's safe before you give it more broadly. Now, the second potentially more interesting issue is the question of the editing itself. So CRISPR is tailor-made to make permanent changes in the genome. And so if you want to change that one letter out of 3.2 billion letters in the genome, you can potentially do that. But then the question is, are you changing any other letters unexpectedly or inadvertently? And does that have any consequences? Now, the genome's a big place. Most of the 3.2 billion letters don't actually do very much. And if you change the letter, it wouldn't mean anything. It'd just be there. But you're worried about potentially having an unintended consequence, hitting another gene, somehow changing its function in some fashion that you might not be able to predict. You know, there's a lot of theoretical concern, although no one's ever seen any evidence of it, that if it's near an oncogene or a tumor suppressor gene, it could predispose cells to becoming cancerous cells. So obviously, this is something that is very, very carefully evaluated. The therapies based on CRISPR that have already started to make their way to the clinic, for example, sickle cell disease, an inordinate amount of attention is paid to whether the editor is doing what it's supposed to be at the intended gene target, and to ensure as much as possible that it's not causing any mischief anywhere else in the genome. But that's something that has to be monitored carefully. And the expectation with a CRISPR therapy, as with all types of gene therapy, is that the FDA will mandate that patients in the original clinical trials will have to be followed for 15 years. That's just pro forma, a requirement for any type of genetic therapy of this type.
Thanks, Kiran.
I was going to ask one quick question, and that is, FH patients, and especially homozygous FH affected individuals, have played such an amazingly key role in the development of essentially every cholesterol-lowering medicine going back to the 70s, and we're going to be calling on them to be volunteers, and many of them are extremely impacted. We also have a lot of people that are really interested in lipoprotein A. Do you think that these kind of therapeutic strategies will be useful for those that are affected with high lipoprotein A?
Yeah, absolutely. So LPA is actually fits into the same category as PCSK9 and AGPTL3, as you well know, Josh. It's a protein that is made exclusively in the liver, and then it is exported into the bloodstream. So because it's made only in the liver, you can use editing to potentially turn off the gene directly in the liver, and then you're done. And then, if you turned it off all the way, that may not be a good thing. I know that you can get by with zero LPA, but LP(a), but if you turned it down to a great degree in patients who have very, very high LPA, yeah, absolutely. At least on paper, this strategy should work quite well.
Great, thank you.
Can I follow up on the LPA question by asking Amit? Amit, how quantitatively, how important do you think LPA is relative to, say, polygenic risk for sort of coronary disease risk? And does LPA get captured effectively in the polygenic risk score, or is there value to measuring LPA on top of doing the polygenic risk score?
Yeah, LPA is a very important driver of cardiovascular disease, and we've seen that the magnitude of risk is comparable. But I think the one thing that's different for lipoprotein a is that it's really the people with very, very high levels who drive the risk, and that's you really need to get to pretty far out in the distribution before you're getting for example, a doubling of the risk. But when we look at the 6 million variants, if you actually go variant by variant and say which are the ones that are get the most weight, it's actually variants in LPA, and so it is capturing to some extent the risk that's incorporated into LPA. But I think if you want a very discrete measure of the specific pathway, there are two approaches. One in which we made a lot of progress, and others have made progress in a genetic predictor specifically about LPA, as opposed to the polygenic score that's much more general across all the pathways. And the second option is of course, to simply measure the LPA. So I think those more specific approaches can be useful if you really want to get at the LPA pathway.
Great, thanks. Josh, I think you were starting to ask another question.
No, I think that was really good. There's a question about evinacumab in the thing in the chat in the questions. And Kiran, I think we should direct this to you. It must be an incredible source of pride to see something like this. Very few people have seen that. Do you envision this moving to patients with HeFH? And just talk to us a little bit about that.
Absolutely, and I think Dr. Rawl could speak more authoritatively about this than I can, because he's been involved in the trials. But there was another trial I didn't mention that was published last year, where evinacumab was assessed in patients with refractory hypercholesterolemia, so not even technically speaking het FH, although I'm sure there was a mix of het FH patients included there, who were already on PCSK9 inhibitors, like the monoclonal antibodies, and already had a substantial amount of reduction of LDL, but still, despite that, had very high or much higher LDL cholesterol levels than they wanted. And when evinacumab, ANGPTL3 inhibition, was added on top of the existing therapies, or on top of the therapies the patients were already taking, there was, again, about a 50% reduction above and beyond what was already being achieved by PCSK9 inhibition and statins and whatnot. So there's absolutely the potential for ANGPTL3 inhibition to be expanded, not just restricted to HoFH patients, but expanded to HeFH patients, to patients with hypercholesterolemia of various types, because it has that double whammy effect. It could also be useful in reducing triglycerides in patients who have very high triglycerides and either have increased heart disease risk because of that, or have other issues such as pancreatitis or whatnot that can arise from very high triglyceride levels. So it's a multi-purpose therapy potentially that could be broadly useful to a variety of different patient groups.
Thank you so much.
I do want to remind everybody, right now it's only approved for homozygous FH.
Yes,
so
that's right.
It certainly has potential, but right now the approval is for homozygous FH. Hey, Kiran, there's a question about what your first in human trial would look like. Like, would there be a placebo group, and that kind of stuff?
Yeah, well, for gene editing therapies, given the severity of the disease that's being addressed, a condition like FH, the first in human studies tend to be typically small, involving no more than a handful of patients, a few dozen patients at most. And typically there is not a placebo arm. This is not my area of expertise, but with a therapy like this, it's pretty clear if editing is occurring. You can assess for the editing. There's not really the same consideration of whether a placebo is somehow going to, through a placebo effect, you're going to get gene editing in the liver and have substantial reductions of cholesterol. I mean, the effect is so dramatic, I think, that a placebo would neither be useful or desirable.
Yeah. By the way, can you just clarify? There was a question about Beam Therapeutics and a recent announcement. If I'm not mistaken, Beam and Verve are collaborators. Can you just clarify that?
Yeah, so the announcement is from Verve. Verve has licensed Beam Therapeutics technology, the base editing technology, for use in the studies that I presented, as well as the work that Verve is generally doing in the cardiovascular disease space.
So question for you and Amit. We now have the potential to drive LDL levels really to the floor, to the basement. Is there a threshold of LDL level that you're comfortable with, or conversely, as we keep getting better and able to do this more and more safely, kind of where do you see the future going in terms of that?
Yeah, I think there are two questions. Is that one is there value beyond which lowering isn't going to get you any clinical benefit? And then the second question is there value where if you go too low, it's not going to be safe? And I think I have to say the safety data has been really remarkable from genetics, from clinical trials, from epidemiology, that low LDL is very well tolerated, and its main side effect is you don't get heart attacks or strokes. And so I tend to be, as you do, pretty aggressive. I think once people are below the 20 milligrams per deciliter range, if they're on multiple medications, I do consider talking to them about backing off one of them. But I think, certainly down to that level, I think there's definitely value. And I guess with for people with garden variety hypercholesterolemia, our treatment armamentarium has really, from a scientific standpoint, come such a long way. And so for the vast majority of patients, if we're able to get the approvals and navigate everything with the doctors and the patients, we actually are able to get people's LDL down to 30 or less, majority of the time. And I think, we heard about some exceptions from Kate and others, but the majority of the time you can. And what it really tells us is that there's an important need to address the small subset of population with homozygous FH. That's one key unmet need. But then the second unmet need is really thinking about other targets and what else can we do to drive cardiovascular risk down. And so we touched on triglycerides like ANGPTL3, lipoprotein A. But I think there's a lot of non-lipid targets that are going to be important. And it's really just as a consequence of the success in treating bad cholesterol down to very low values.
Kiran, anything to add?
No, I agree with everything Amit said. Eugene Braunwald, who's commonly recognized as the father of American cardiology, is a very aggressive proponent of, lower is better, and what he's told me. I think the story he likes to tell is that anytime a new therapy becomes available, he's like first in line to take in, and has driven his cholesterol levels as low as they can possibly go. So I subscribe to that view of the world, shall we say.
And I was actually going to say that he gave cardiology grand rounds at Penn recently, and he was specifically asked this question. Yep. And he basically said he's pretty much attempted to really keep his LDL at about 20. Josh, anything else you want to add?
I was going to say, this is so inspiring. I think I want to give a shout out to Kate, to Catherine, and to Kat, and all the individuals that have been impacted by FH, because we're at a place of incredible hope for people with homozygous FH, for heterozygous FH, for high LPA, as highlighted by the last summit that we had. And a lot of that is not just driven by the scientists and the doctors, but it's really driven by the advocates and the patients and the families and the mothers and the fathers. And so just congratulations. It was such an inspiring talk. And Kiran, thank you for your talk, and Amit as well. I did want to highlight that we are going to have our next summit on March 17th. So please return. Implementing innovations in FH care. The speakers are listed here below, and they're fantastic. And we hope that you'll join us again. But once again, thank you for the incredible audience, and please, this will be available to you later if you register. So thanks so much.